Center. Please join me in welcoming Dr. Margaret Bordeaux to the podium.
Well, my first question is, couldn't you get a bigger room? This one's a little bit too informal, you know. Thank you so much for that extremely kind introduction. It's an enormous honor for me to be here today with all of you. And I'm especially keen to be here because I'm actually married to a man who I was born and raised and grew up in this neck of the woods in Ottawa, right across the river. And as fate would have it, tomorrow happens to be our 20th wedding anniversary. Yes. Yep. We're going to celebrate a little later, yeah. I do live in Boston, but I do feel the need to immediately tell this audience that all of our children play hockey, so you can rest assured. But I do mention this because we sometimes play an admittedly self-centered game when reflecting on our marriage, which is to think about all of the world events that had to happen to transpire for the two of us to meet and to fall in love and to have a family. He's an Ottawa boy and I'm an American mutt from the South. And one of those events that transpired was the massive refugee crisis that followed in the wake of World War II, when my husband's grandmother, a young mother of two at the time, fled Latvia as the Soviets took control of Eastern Europe. She became one of hundreds of thousands of refugees that made their way to Canada, where she raised my husband's mother and 4 other children. So I want to begin my talk about health system resiliency in the face of threats like armed conflict with that historical period in mind. Like now, it was a period of enormous uncertainty and geopolitical contest. Like now, the future of democracy was uncertain. Like now, there were myriad economic, humanitarian, and security challenges bearing down on countries around the world. And like now, the burning question of the times was what institutions were needed, nationally as well as globally, that could sustain and underwrite human security for the long term. Or would humanity be condemned to live in a world of constant catastrophe, violence, poverty, and suffering? Well, by and large, our forebears did indeed rise to the challenge of those times, imperfectly and haltingly, no doubt, but many of us sitting here have reaped the benefits of the institutions created in that 2-decade period after World War II. And I want to invoke the spirit of institution building and strengthening today as we think together about the issue of health system resiliency. With that in mind, my goal here today is threefold. First, yes, I am here to issue a warning about a potential immediate threat to health systems of all NATO member countries as the alliance's confrontation with Russia continues and intensifies. But I'm at the point in my career where I have learned that issuing warnings and raising alarms is not enough. In fact, given that we are living in a world of many different dangers and catastrophes and risks, it's pretty easy to say, hey, there's a problem over here and somebody should do something about that. Walk away. Job well done. I've come to realize that often warnings about threats to health systems go unheeded because leaders lack the tools and resources they need in order to systematically think through potential mitigation measures. So in the second part of my talk, I'm going to lay out elements of a resiliency-centered approach to health system threat mitigation that I think can help leaders feel less overwhelmed and paralyzed in the face of multiple warnings about potential crises. Finally, in the third part of my talk, I'm going to present an overview of another tool I think can facilitate health system threat mitigation. It's a health system vulnerability assessment framework that can guide thinking about the ways different threats can disrupt health systems, consider how disruption in one health system domain may affect other parts of the system, and promote health system resiliency in conflict-affected settings. So first, the warning. Canada, like all 31 member states of the NATO alliance, is increasing its commitment to confronting Russia as it continues its assault on Ukraine. Canada, as I understand it, is poised to have more than 2,000 personnel in Latvia and other frontline nations in the coming months. As confrontation with this adversary intensifies, it is worthwhile to consider how Russia has prosecuted warfare to date. Russia has fought in multiple conflicts over the last 2 decades, including 2 wars in Chechnya, the war in Georgia in 2008, in Ukraine in 2014, in Syria in 2015, and now in Ukraine again. Attacks on healthcare workers and infrastructure occurred during all of these conflicts, and indeed, Russia was hardly alone in this regard. Attacks on healthcare have occurred in many conflicts, including Afghanistan, Yemen, Democratic Republic of Congo, Tigray, and Ethiopia, and etc. However, Russia's engagement in Syria in 2015 seemed to mark a shift when attacking health facilities and workers became a core strategy of how they prosecuted warfare. Multiple studies have documented over 600 attacks on health facilities in the course of the Syrian conflict, with more than 200 involving the Russian Air Force. One of many excellent reviews of this problem was conducted by Elise Baker and Jisoo Nia at the Atlantic Council. In it, they lay out the evidence that these attacks were systematic and deliberate and were intended to break the will of the civilian population and essentially beat them into submission. In other words, these attacks were not a matter of collateral damage occurring in the course of an military target. For example, they analyze how the pattern of shelling and bombing of health facilities suggests an intentional attack, noting, 1, the locations of hospitals was known. In fact, health facilities registered their latitude and longitude with the UN so that the UN could alert the parties to the conflict of the locations to avoid targeting. They were located in isolated areas where there were no other possible targets. There were frequent double tap strikes in which a hospital would get hit and then hit again 20 minutes later after first responders had moved in. The attacks were repeated, with the same facility being targeted week after week, and they were concurrent with attacks on other health facilities in the area, knocking out all of the health facilities in the entire region. An incredible investigation also by the New York Times was conducted. The New York Times obtained thousands of recordings of Russian Air Force radio traffic in Syria and conducted an investigation that leaves little doubt that these attacks on health infrastructure were deliberate, planned, and strategic. Here are 2 still shots from the New York Times video explaining their investigation. In this instance, the hospital being bombed here has gotten word it was going to be targeted after it submitted its location to the UN, and so they evacuated and set up a video camera. Here you can see in the top frame the second bomb being released in the square there, and in the bottom frame you can see the result. In Ukraine, we saw the same pattern over the course of the first year of the war. Hundreds of attacks on health infrastructure and workers within a short time period, especially in the beginning of the conflict. There has been widespread condemnation of these attacks, and there has been some progress on prosecuting them as the flagrant war crimes and crimes against humanity that they are. But I'm going into some detail on this because I want it to be clear That intentional targeting of health system elements is now part and parcel of how Russia is conducting warfare. And I have yet to see serious consideration on the part of NATO allies as to how Russia's behavior in this regard might constitute a problem for their own fighting forces and their own civilian populations. I like to call this the Guam brown snake phenomenon. In the 1990s, brown snakes were introduced to the island of Guam. Previously, Guam had not had any snakes at all, and the brown snake quickly decimated the bird populations on the island. There are these incredible videos of snakes crawling up and along the branches and birds just sitting there and not flying away, even as they watch a fellow bird being devoured. This lack of experience meant that while the bird presumably felt badly for its winged companion getting eaten, it didn't register that it too could be in danger. So this was one of the last things the birds saw. I don't want NATO member nations to be the birds in this scenario, okay? To avoid being the bird, it's worth considering what is the strategic advantage Russia is getting from attacking health infrastructure and workers. Well, there are several, like breaking the will of the civilian population, but another is that destroying healthcare delivery degrades the fighting readiness and combat capabilities of its adversaries. I know I don't need to tell this audience how important healthcare is to maintaining the combat capabilities of the armed forces. Troops need trauma care, and they also need treatment for all sorts of non-combat related conditions, injuries, infections, chronic illness, mental health. Moreover, if there is no medical care available, it is you have a natural aversion to putting yourself in harm's way. So destroying the health systems that provide care for military personnel, unfortunately, make great strategic sense. The rub here is that, with the exception of the US, every NATO member's armed forces rely heavily, if not completely, on the civilian health systems of their countries. I'm going to say that again. The rub here is that, with the exception of the US, every NATO member's armed forces rely heavily, if not completely, on the civilian health systems of their countries. So the concern here is that as NATO nations confront Russia, their civilian health systems could come under increasing threat of disruption by a determined adversary who is not seemingly deterred by the dictates of international humanitarian law. Now, it is, of course, completely reasonable for Canadians to say, well, this is concerning, but I really don't think that Russia would be so bold as to bomb our deployed medical assets or any elements of our civilian health system here at home. I, by and large, agree that my warning is more resonant with European health system leadership in states geographically proximate to Russia. However, our work on health system disruption in conflict-affected states illuminates that civilian health systems can be disrupted in many ways, often in ways more durable and impactful and long-lasting than bombing health facilities. In fact, from an institutional perspective, health infrastructure is the easiest to recover. Case studies of health systems in conflict, where we have done case studies over the past 2 decades, show the many different ways that health systems can be disrupted. I've listed some on this slide, and I'll briefly touch on them, although I'll go into a little bit more detail about them in a moment. Interruptions or fracturing of leadership can leave health systems rudderless and unable to respond to the needs of the population. Financing can be diverted to defense, or the conflict ensures that traditional sources of revenue used to finance health systems are no longer feasible. The problem of health workforce attrition is very difficult. Cyber attacks on health information infrastructure can be devastating, and mounting burdens of disease can overwhelm health facilities. Suffice it to say, an inclined adversary can find many ways, short of bombing, to damage and disrupt health system functioning, drive up the costs of care, and increase the burdens of disease a health system has to address. A final consideration here for Canadians. Maybe your own civilian health system experiences no problems, but the fact is that the destruction and degradation of health systems of other countries opposing Russia, including Ukraine's, saps the overall strength and fighting capability of the alliance. In fact, that's what it means to be in an alliance. You're only as strong as your weakest link. This is why I believe preserving health systems and promoting civilian health system resiliency should be a core strategic element of how NATO advances collective security. So hence my warning. Canada and NATO allies collectively need to recognize, A, as the conflict with Russia escalates, health systems that support your armed forces as well as your civilian populations may be targeted in some way. You need to prepare with your civilian health system counterparts for this possibility. And B, that health system disruptions in Ukraine and other European countries are a problem for the entire alliance. So this is the point in the talk when I distinctly detect a squirm from my military medical colleagues and a deep sigh from my civilian health system leaders. In the security and military medical community, there can be a sense that, oh yes, this is important, even critical. But there's a lack of clarity about how to raise it with civilian health system counterparts at the right level. Even maybe a lack of clarity about who the right health sector counterpart might actually be, especially in a country with a federated or regionalized health system. There can be a sense that, hey, I really don't know too much about this health system stuff, and maybe I'll just raise it with a deputy, and hey, I've raised it, and then it's up to them to escalate to civilian leadership, right? What we are finding, however, is that for many civilian health sector leaders, this issue is coming out of left field. Even in NATO countries at greatest risk for direct military engagement with Russia, there's a sense, what are you telling me to worry about? Like, take a number. I've got several million concerns and challenges bearing down on the health system, and good grief, I am not here to think about armed conflict at all. We received exactly the same kind of response in 2019 when we tried to talk about the problem of pandemics. Yes, that would be terrible, but I can't think about it right now. I've reflected a lot on why this is such a common response, and in working with health system leaders on a wide array of crises, I have to say, I see their point, right? They are having to contend with many different possible challenges and potential problems. Why should they deal with this one first or at all? I have concluded that leaders responding in this way are being pinned in by what I call a threat-based approach to disaster preparedness, which is like playing whack-a-mole. There is a need to switch to a resiliency-centered approach. And this is where I have found the work of my colleagues in the field of disaster management particularly instructive. So I'm going to review with you a few of the key principles of a resiliency-centered approach compared to a threat-based approach so that we can all consider this together to think about how we can help our civilian health system colleagues make a switch. In particular, I've learned a lot here from my colleague, Professor Juliette Kayyem, who has just come out with a new book called The Devil Never Sleeps, and here she is with her glam shot. I'm not making any money by promoting her book. I just am putting it up here because I'm going to quote it at length, and I just want to make sure that I cite her properly. But in it, Professor Kayyem talks about 2 sea changes that have happened in the field of disaster management over the last 2 decades that speak to this problem of constantly being overwhelmed by crises. The first is that there has been a shift in the field being scoped around preparedness for individual or specific threats to an all-hazards preparedness model. And 2, a recognition that prevention is not possible 100% of the time, or even the majority of the time. Bad things are going to happen. Her mantra is, assume the boom. The boom here is a crisis, and she uses this simple framework to think about left of boom preparedness versus right of boom preparedness. Left of boom preparedness focuses on preventing the boom, and right of boom preparedness focuses on mitigating the harms that come from them. She points out that a lot of attention has been traditionally placed on prevention, left of boom activities, but in a world where the devil never sleeps, we need to increase our focus on right of boom preparedness. Living in a world where we acknowledge booms are going to happen and health systems are going to be challenged by a wide array of unexpected crises has multiple implications. First and foremost, it means that leaders in the health sector need to be engaged in the disaster management business. Disaster management can no longer be something that one hires some guy to do, and then you send him on his way while you deal with the day-to-day. Rather, thinking about and preparing to mitigate crisis has to become part of the day-to-day. It also means that health sector leaders can't assign a point person to just take on one type of boom and come up with a plan, because leadership is quickly overwhelmed by the number of potential crises and the conflicting plans to manage them should they occur. This sparks something called prioritization flatlining, when all potential scenarios are equally compelling, so there's no way to prioritize them. For example, in some ministries of health I've worked with, the director has assigned one person to be in charge of cyber attack planning, another person to be in charge of pandemic preparedness, another to be in charge of natural disaster planning, another in charge to be in charge of mental health crises. And then all these point people dutifully come back with their plans and elaborate stakeholder arrangements, and the poor director is stuck, right? They're pulled in so many different directions and unsure of which to prioritize, how to reconcile overlapping parts of different plans, and how to maintain relationships with stakeholders. With an all-hazards approach, the focus is on how you protect your system's core functions, regardless of the precise nature of the threat. Then you develop useful strategies that are useful in many different contexts. Some of these general strategies include things like designing redundancies, backups for important databases, avoiding single-point failures, installing breakers to prevent cascading failures, creating reserve or surge workforces, or investing in the ability to have situational awareness during an emergency. Another difference in these two approaches is how learning takes place. In a threat-based approach, learning is static. There can be many ad hoc solutions that are taken down the minute a crisis has passed and never memorialized, or maybe there are dusty tomes of lessons learned and after-action reports that sit under couches and behind bookshelves that you maybe stumble upon as you're frantically looking for something else. Right. In a resiliency-centered approach, learning is continuous. There are red team challenges, simulations, tabletop exercises, commonly, so that everybody gets a chance to practice what to do when the unexpected happens. Finally, the mentality of leadership is different. I can always tell when a health system leader is using a threat-based disaster management approach because I usually find them in a defensive crouch, repeating over and over, I have it all under control, I have it all under control, nothing to see here. If you've ever tried to work with a leader who is in a defensive crouch, you know how impossible that is. And it's easy to get frustrated and kind of give up. But if you've been a leader in a defensive crouch, you know it usually has little to do with your leadership abilities and a lot more to do with the processes and resources you have access to that can facilitate an all-hazards resiliency-focused approach. So now, instead of getting upset with leaders in defensive crouches, I've started trying to understand what is the administrative infrastructure they have access to that can guide them through this problem-solving space. right? What is the administration that they can go to that will help them do these red team exercises and simulations and assess their vulnerabilities and make mitigation plans across sector? So my first question to ministers of health that I've been starting to work with about any threat, in this case armed conflict, is what is your administrative body that can facilitate and spearhead thinking about this? For my preparation for this talk, it sounds like the Canada Public Safety is the national agency here with a lot of experience potentially in this regard, routinely running tabletop exercises with multi-sector stakeholders. And the work that it strikes me that could begin right away, right, with their help potentially, is to game out what would happen if there were an increasing number of Canadian Armed Forces casualties in Eastern Europe, and what would happen if Russia decided to try to disrupt or prevent them receiving medical care. This, in some sense, is a sort of straightforward problem. It's very difficult logistically, no question, but it's straightforward. However, to tackle the bigger question of how to prepare Canada's health system for a major disruption, let's say a multi-pronged deliberate attack designed to be maximally damaging, put financial stress on the system, delay or deny care to a large number of civilians, and foment public anger toward the Canadian government, setting that scenario up is harder, right? And the reason it's harder is that to date, there isn't a serviceable operational model of a health system. In fact, there really isn't consensus on what constitutes the core processes of a health system. To fully move from a threat-based approach to a resiliency-centered approach, you have to know what the core processes of your enterprise are that you need to protect. You can't protect something that you can't define, right? And this is a gap that I see as important for health system researchers and academia to address. So for the last part of my talk, I'm going to provide an overview of some of the work my team is doing to develop a health system vulnerability assessment framework, a way for stakeholders be able to identify how health systems can be disrupted and how disruption in one domain will affect other parts of the system. And to explain it, I need to give you a little bit of a brief overview and some context about the field of health systems research and how it has evolved over the last 2 decades. So it may surprise many of you to learn that there really isn't consensus about what the core processes of a health system are. But this is because there is a lot of variability across countries in terms of how health systems grew and evolved. The idea that every country would have a health system that would provide universal health coverage is a very new idea and remains controversial in some quarters of my poor country. But in fact, 15 years ago, there was no consensus definition of a health system really at all. And there was a lot of activities people were calling health system strengthening. But they ranged from donating containers of albuterol to poor countries, or providing uniforms, or creating curricula for health workers, to building clinic buildings, sometimes with no staff. And all of these were sort of called, health system strengthening. So the WHO, so this lack of clarity and strategy about health system strengthening motivated the WHO in 2007 to produce what is often referred to as the building block model of health systems. So the WHO had 2 goals in doing this. The first was to describe, and categorize the different activities that constituted health system strengthening, a description, right? And to build consensus around what the outcomes of a well-functioning health system should be. So this is what they came up with. I'm going to start on the right there in terms of the outcomes. So they documented 4, they came up with 4. I'm going to just go through 3 because they're my favorite, and I think they're quite solid. But they came up with 3 that were really important. They said, if you have a well-functioning health system, you should have an improved health of your population. That actually was probably the most controversial thing in there, because that's actually a question that for a long time people were like, well, does healthcare matter? Anyway, that was one. Two was, skipping to the third one there, financial risk protection. So they said a well-functioning health system is one in which people don't go bankrupt from paying for medical expenses. Again, super controversial for some reason. Third is the one in the middle there, which they called responsiveness, which is kind of a little bit of an odd term. But that sort of chimes with one of the outcomes I'll show you in another model, with the idea and the sentiment that the population should think that the health system is doing a good job, that it's addressing their top needs. Okay? So that was a really remarkable contribution the WHO did, was really defining what we thought health systems should be able to do. Then on the left side, they sort of offer these, what they call building blocks, or sort of descriptors. Service delivery, health workforce, information, medical products, financing, leadership and governance. So these were nice sort of descriptors. However, there was a lot of complaints about the left side here. So you can imagine that describing things in what a health system is descriptively like this is a little bit confusing. And to use a hockey analogy, which I've been dying to use, pretend that an alien comes to you and says, what is this game of hockey? And you say, well, it's ice, and there's skates, and there's pucks, and there's sticks, and there's a goal, and there's maybe teams, and then, it wins. You wouldn't really understand how the game of hockey is played, right? Or what it's about. So around the same time, the World Bank was looking to make investments in health system strengthening and promote health system strengthening policies. They, working with some folks at my institution, created something called the Flagship Framework Model. And this model was written for policy reformers trying to improve the outcomes of their health systems. They wanted to understand how different policies would impact health system outcomes. Okay? The idea here was that there are a finite, so the health system in this model, you can see again on the left, they use outcome measures that are sort of analogous to the World Health Organization's. But how they conceived of this model was a health system as a control panel, with different types or groups of policies are described as control knobs or control dials that policymakers can adjust to different settings. They described 5: financing policies, payment policies, organizational policies, regulation, and persuasion. The idea here is that there was a finite number of ways, for example, to finance a health sector. And each different way you finance this sector has a different effect on your health system performance. So if you choose one financing model, you will have a different degree of risk protection for your population, say. The great thing about this model was that it was operational. If you do X, the effect of health system performance will be Y. If you put the puck in the net more times than the other team, you will win the game, right? It also provided an opportunity to compare different countries' health systems structurally along a policy, at least comparable in terms of policies. The problems of this model, for our purposes of wanting to understand health system vulnerability, how a health system can be disrupted, are threefold. 1, where's the middle? What is the mechanism by which these policies are implemented and lead to these outcomes? You can have all the best ways to pay for care in the world, but if you don't have health workers or infrastructure to deliver care, then you aren't going to see these outcomes, right? 2, who is in the control room? This model assumes there is clarity and agreement on who is setting the dials. In many of the places I work, leadership of the health system is contested. In many crises, there is a lack of clarity about who is in charge and who is directing policy. 3rd, the model assumes a steady state and no relationship between the outcome variables and the system. But in crises, you have mounting burdens of disease, say. The health status of your target population is changing, right? And the number of patients can then overwhelm the system. So this model doesn't account for any of that type of dynamic. So we have started to tackle and take the best parts of these two models and build on them to develop this health system vulnerability assessment framework. We envision a health system to be composed of sort of 3 levels, here going left to right, each one producing the next level. So leadership is on the left. Leaders set policy for the system. We kept the control dials the same, although in conflict-affected states, they probably need to be tweaked and retailored a bit. Financing, for example, is heavily donor-dependent, and so there needs to be some redefining of the policy settings for that control knob. The policy control room, or the policy platform, in turn produces what we call the health delivery platform. That's all the stuff that touches patients, right? The workforce, the infrastructure, the supply chains, the services, right? The health delivery platform produces the outcomes, which we kept the same title for the different outcomes we're seeking, even though they are slightly different. They have slightly different meanings in the context of potential disruption. Finally, we envision how these outcomes can, in turn, impact different parts of the health system. So we are working to fully describe this framework and how it can be used by health system leaders to game out, 1, the points of vulnerability in their health system, how different threats could disrupt their health system and in which ways. And 2, think about how disruptions in one domain will affect others. We also hope that this framework can be useful in mid- or post-conflict or crisis scenarios for health system leaders to communicate their needs and generate strategies to shore up faltering health system elements. We are hoping to work with countries concerned about health system disruption to beta test this framework and further refine it. And we are hoping other academic researchers will jump into this space and come up with other ideas and approaches as well. I'm hoping some of those people are sitting in this audience. So to conclude, I do want to leave you today returning to the theme of institution building and strengthening. Yes, I know the future looks quite scary. There are an enormous number of potential catastrophes bearing down on us that threaten our systems and our way of life. But I am confident that if we take a resiliency-centered approach and invoke the same spirit of institution building and strengthening as our forebearers, we can indeed develop and sustain the institutions that will underwrite human security for generations. Thank you.